All right, we are rolling. Em, if you can start the webinar, please. And good morning, everyone. Welcome to today's New York City Council hybrid co-committees on Committee on Hospitals, jointly with the Subcommittee on COVID Resiliency and Recovery. At this time, please silence all electronic devices. If you'd like to submit testimony, please do so to testimony@council.nyc.gov. Again, that is testimony@council.nyc.gov. Thank you for your cooperation. Chairs, we are ready to begin.
Good morning, everyone. I'm Council Member Mercedes Narcisse, Chair of Committee on Hospitals. I'd like to start by thanking the co-chair of this hearing, Council Member Moya, for this important discussion. I also like to thank my colleagues for being present today. Ms. Rita Joseph, Council Member on Education. We have been joined by council members. No, not yet. Because anybody can see her on the screen? Not yet. Today, we'll discuss long COVID treatment in New York City hospitals. As the COVID pandemic continues, more and more people are experiencing long COVID symptoms. Symptoms of long COVID can include tiredness, fatigue, fever, respiratory, and heart symptoms, neurological symptoms, depression or anxiety, digestive symptoms, joint or muscle pain, and several other symptoms. There are also reports of people who have recovered from COVID being more prone to develop new health conditions such as diabetes, heart conditions, or neurological conditions compared with people who have not had COVID-19. This is an enormous concern. According to the CDC, estimates of the proportion of people who had COVID-19 that go on to experience post-COVID condition include 13.3% at 1 month or longer after infection, and 2.5% at 3 months or longer. Based on self-reporting, for those who were hospitalized, more than 30% experienced long COVID symptoms at 6 months. Even though many people will recover from COVID-19 and will not experience long-term symptoms, given the sheer number of COVID-19 infections, long COVID is a severe health concern for our city hospitals, clinics, and residents. Thousands of people in New York City continue to test positive for COVID-19 every single day. Utilizing the CDC estimates, at least tens of thousands of New Yorkers may be living with some long-term health impacts of COVID-19. Additionally, given the disproportionate impact of COVID-19 on Black and Latinx communities, immigrant communities, older communities, and others, particularly at the beginning of the pandemic when vaccines were not available. We know that there are equity concerns tied to this topic. Today, we will examine what we are doing to help New Yorkers with long COVID and discuss what more may need to be done. I very much look forward to hearing about H&H COVID Center of Excellence, which I had a chance to visit about two of them now, and the Test and Trace Corp and T2 Aftercare Program. For example, those with long COVID may experience stigma, dismissive attitudes, and frustration with how much there is left to learn about their conditions. I'd like to hear about how H&H and T2 are working with those with long COVID to ensure that their needs are being met and that they are receiving compassionate care. The T2 Aftercare Program, which is for those recovering from COVID, note on its site that addition to its medical impact, long COVID also has social and economic implications, particularly for population already disproportionately burdened by health inequities. Fatigue and pain can affect mobility. Concentrating at work is harder with brain fog. And anxiety and depression can alter one's outlook on life. The T2 Aftercare program supports New Yorkers with long COVID by connecting them with resources that meet their health and social needs. I'd love to hear more about this work and what resources are available, including how this connects to H&H COVID Centers of Excellence. I thank the administration for being here today and for their tirelessly work since the pandemic began. I also thank Chair Moya again, as well as the members of the hospital committees and the subcommittee on COVID recovery and resiliency for joining us. I also thank the committee staff for their work on this issue. Committee Counsel Habani Hahuja, Policy Analyst M. Balkan, as well as my amazing team, including Syed Joseph, Frank Shea, and the rest of my staff that have been working on this. I will now turn it over to the co-chair for this hearing, Moya. Thank you.
Thank you, Chair Narcisse. Good morning, everyone. I'm Councilmember Francisco Moya, Chair of the Subcommittee on COVID Recovery and Resiliency. I'd like to start off by thanking the co-chair for this hearing, Councilmember Narcisse, for this important discussion. And I'd also like to thank my colleagues for being present here today. Today we're here to discuss long COVID treatment in New York City hospitals. COVID-19 has had a devastating impact on the health of New Yorkers. Since early 2020, millions of New York residents have contracted the virus. While COVID-19 is still new, we continue to learn more about its effects, both short and long term. We know the impact of the virus can last long after an individual recovers from the typical COVID-19 infection. For many folks, COVID-19 infection leads to long COVID or a wide range of new, returning, or ongoing health problems that can last weeks, months, or even years after first being infected. As my co-chair mentioned, symptoms of long COVID can include a wide range of symptoms that affect both physical health, such as fatigue, respiratory, and heart symptoms, and digestive, mental health, such as depression and anxiety. Some people may also be more likely to develop new health conditions compared with people who had not had COVID-19. Estimates show that as many as 24 million Americans have experienced long COVID symptoms. The Mayo Clinic has reported that long COVID is not rare and occurs in at least 10 to 20% of people who have had COVID-19. The overwhelming majority of people with long COVID, approximately 75%, only had mild illness with COVID and did not see their doctor or go to the hospital. Long COVID also appears to be more common in younger people and more common in women than men. While studies are still ongoing, we are still understanding what exactly causes long COVID. Research has begun to indicate that certain patients might face a greater risk of long-term symptoms. This includes people who have experienced a more severe COVID-19 illness, people who've had underlying health conditions, people who did not get a vaccine, and people who have experienced multi-system inflammatory syndrome during the COVID-19 illness, and some people affected by health inequities, including people from racial or ethnic minority groups and people with disabilities. As new COVID-19 variants continue to emerge, we must continue to focus on the long-term effects that this virus has on the health of New Yorkers. How do we work to ensure that people with long COVID are not dismissed if they have difficulty explaining or proving their symptoms? How do we ensure that folks with long COVID do not find themselves falling through the gaps in the social safety net? How long COVID treatments and services can we invest? How long can treatments and services we can invest in to improve the overall health of New Yorkers? These are questions that my colleagues and I hope to discuss with the administration today. I look forward to hearing from H&H's COVID Center of Excellence and the Test and Trace Corps aftercare program. I want to thank the administration for being here today. I look forward to our discussion. I want to thank again Chair Narcisse, as well as the Subcommittee on COVID Recovery and Resiliency for joining our hearing today. I also want to thank the committee staff for their great work on this issue, Committee Counsel Harbani Ahuja, Policy Analyst M. Barkin, and my Chief of Staff, Megan Taddeo. Thank you, and now I'd like to turn it over back to Chair Narcisse.
Thank you, Chair Moya. I will now turn to Committee Counsel to administer the oath. Thank you.
Thank you, chairs. Members of the administration, if you could please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee, and to respond honestly to council member questions? I do. Thank you. Just please state your names for the record, and then you can begin. You get started.
So good morning, chairpersons, Narcisse Moya, members of the Committee on Hospitals and Subcommittee. It's like when you forget the WebEx, you unmute yourself. Good morning, chairpersons, Narcisse Moya, members of the Committee on Hospitals and Subcommittee on COVID Recovery and Resiliency. I am Dr. Ted Long, Senior Vice President for Ambulatory Care and Population Health at New York City Health and Hospitals, and I've served as the Executive Director of the New York City Test and Trace Corps since its launch in June of 2020. Thank you for the opportunity to testify in the work of New York City Health and Hospitals has led to understand, treat, and support long COVID patients. While we're still learning about the depth and extent of long COVID, New York City Health and Hospitals is proud to be at the forefront of offering comprehensive clinical services to meet the needs of patients who are navigating this emerging condition. Our commitment to supporting long COVID patients has resulted in the creation of two key programs. Through the opening of new community-based COVID-19 centers of excellence in neighborhoods that experienced some of the most devastating impacts of the pandemic, and through the launch of aftercare. New York City Health and Hospitals recognized early on that long COVID was an emerging clinical issue and began planning to open COVID-19 centers of excellence sites in the fall of 2020. It was critical to our hospital system leadership that the COEs, or Centers of Excellence, were located in the regions of the city hardest hit by the pandemic, Bushwick, Jackson Heights, and Tremont, in order to deepen access to specialized healthcare services in communities most likely to need them. The COEs provide short and long-term care for those recovering from COVID-19. Services include lung care and supplemental or extra oxygen, heart care, x-rays, scans, and ultrasounds, mental health services for anxiety, depression, post-traumatic stress disorder, and psychological distress. Rooms to safely isolate patients who may have COVID-19 or being tested for COVID-19. COEs work to treat the whole patient and thus offer comprehensive primary health care services, including cancer screenings, dental and vision care, diabetes management, podiatry, adult medicine, pediatrics, and much more for not only patients with long COVID, but for all patients and their family members without exception. Patients can be referred to the Centers of Excellence after a hospital visit, through their primary care provider, or through our aftercare program to receive short and long-term care to address their recovery from COVID-19. For aftercare, in April of 2021, New York City Test and Trace Corps launched the aftercare program, which connects New Yorkers with long COVID to resources to support them in their recovery process. To address the various symptoms long COVID patients may experience, as well as the social and economic impacts that the conditions may create, such as loss of employment or social isolation, aftercare navigators connect patients to holistic resources that address physical health, mental health, community support, and financial assistance. Aftercare makes phone calls to former COVID-19 cases who are still reporting symptoms at the end of isolation. Clients are directed to the aftercare website, nyc.gov/aftercare, or they can select the resources most relevant to their needs and get connected. New Yorkers who are suffering from or believe they may have long COVID can also directly call aftercare navigators, health outreach specialists with experience supporting people during their COVID infections. Through this program, people can be assessed for their specific health and social needs and connected to long COVID resources. Individuals suffering from long COVID can call 212-COVID-19, that's 212-268-4319, select their preferred language, and press 4 to speak to an aftercare navigator. Since the launch of aftercare in April of 2021, Aftercare navigators have sent more than 334,000 texts and completed over 114,000 phone referrals for New Yorkers who have recently been diagnosed with COVID-19, following up approximately 4 weeks later if the patient reported having symptoms on the last day of their COVID-19 monitoring. Aftercare navigators have sought to prioritize patients in zip codes identified by the Task Force on Racial Inclusion and Equity, TRIE, as disproportionately impacted by COVID and other health and socioeconomic disparities. New York City Health and Hospitals has a long history of meeting the healthcare needs of all New Yorkers, regardless of insurance, income, and immigration status. We look forward to continuing this work to partner with the City Council and all local stakeholders to expand access to critical healthcare services in this city. Thank you to the committees for your attention to this important topic and for your continued support of New York City Health and Hospitals. I look forward to answering any questions you may have.
Thank you again. I appreciate taking the time, Dr. Long, to be here. And I had a chance to visit 2 of the excellence centers, and I'm very much impressed. We came a long way. Having said that, I know that we're hit hard in many communities, right? Many of high-risk communities. So now, from my understanding, is 3 areas that we have the centers right now, right? Mm-hmm. We have it at Bushwick, Tremont, and Jackson Heights. I had a chance to go to Bushwick and East Tremont, and I loved it. It's beautiful, state of the art, the equipment, everything is great. The services, I could say so far, I'm very impressed as well. As a nurse for 3 decades, I'm always focusing on preventive care. So, what do you determine? What do you base on? What matrix you use to determine where to put the centers exactly?
That's a great question. So I want to start by saying that when we decided initially where we wanted to place the centers, this was years ago now in the pandemic. We were very early to open COVID centers of excellence, and since we have, many others across the city and country have followed. So when we initially chose these 3 locations, these were chosen based on those communities disproportionately impacted by the initial waves of COVID. So we knew we needed to move fast right out of the gates. We opened these centers. We're seeing patients now, but this is not the end of the story. We want to continue our goal is to support all New Yorkers, to make sure that any New Yorker with long COVID can have access to one of our centers or one of the other centers across the city that has been started since we started to create our centers of excellence. If there's a need in other communities, we'd love to hear from your perspective where that need might be. But our goal is to do the best job we can with our first 3 centers, which, by the way, as you know, we built these centers which otherwise would have taken 6 years to build in about 6 months. We pulled out all the stops to help New Yorkers, and we want to continue to do that moving forward together.
I know and I do believe you, but I live in the 46th district, which cover Canarsie, Flatlands, Bergen Beach, Mill Basin, Mill Island, Marine Park, Garrison Beach, and Shipshead Bay. But Canarsie area hit hard. So I know we're in the conversation. I've been talking about it. So where are we in the phase? Because I know we have to open more. Because my goal is every high-risk area, not only my area. I know East Flatbush as well. A lot of people die. So those are the high risk where we have the diabetes, hypertension already, heart disease and all. So where we are in the plan, when we're going to see the next centers, because my goal is to have it throughout the city in all high-risk area, not specifically those 3.
I am, at the end of the day, just a primary care doctor. I love seeing my patients. It means a lot to me we're able to offer these centers of excellence to New Yorkers. I would love nothing more than to partner together to open up more centers in the areas where we can work together to figure out where the highest needs are. But you can count on New York City Health and Hospitals providing all of the clinical expertise that we have in the centers that you've visited and to all communities across New York City that need us. We are ready to be there with you.
I appreciate that. You mentioned about the phone number, 212 COVID-19.
Yeah.
How do you do to promote it? What do you do to promote it? What kind of marketing strategy are you using right now to make sure, because most people don't know about that 212 COVID-19?
So if I was to make one, I think, important point from my perspective, having addressed COVID for what feels like a very long time now, it would be that I think that our ability to meaningfully treat long COVID as a city really relies on our ability to inform New Yorkers about the resources that we have. We've built these centers, we've created this phone line, which, by the way, is a one-stop shop for everything that you might need from COVID. It connects you, if you press 4, to an aftercare navigator. If you press 9, in a matter of minutes, you could be on the phone with one of our emergency room doctors and have Paxlovid sent to your home if you have COVID and you meet the criteria for it. You can also have questions answered by clinical staff, and you can find out where to get tested nearest to you. So the phone number itself is a one-stop shop for a variety of things. It will only ever be as effective as we're able to communicate to people about it. And I would love your help in communicating, especially to the people that you know haven't heard about it yet. And would love to your feedback on how we could do a better job of that. But we built the phone line to use it. It's a fantastic resource for New York City, and we'd love to work together to help to get the word out so that everybody in New York City knows 212 COVID-19 is where I can go for anything related to COVID for myself or my family.
You know, I appreciate your work once again as a medical person myself. I will suggest that you use more of the CBOs within the community, the churches in the community, just like we did for census. Keep on pushing it, making sure that, because COVID, unfortunately, I don't think is going to go anywhere anytime soon. We have to deal with it. Approximately how many patients does HNH serve who have long COVID symptoms? Does HNH collect any data regarding long COVID? Could you give an estimate of how many patients were hospitalized then go on to experience long COVID symptom? What additional, please take note because I have a few to add, what additional support do those with long COVID need? Recently, the CDC released a report which found that COVID-19 survivors have twice the risk for developing pulmonary embolism or respiratory conditions. Have you seen this occur at HNH? Do you feel the general population has a good understanding of the potential risk of COVID?
A great series of questions. Let me do my best to answer them sequentially, and if I do miss any answers, please call me out in it, and I can go back to them. So, with respect to, the first part I'll answer is the way that we formulated our centers of excellence is we looked at the time, and have continued to do this, of all of the evidence of what the primary or most common symptoms are of patients suffering from long COVID. For example, shortness of breath or cardiac issues. That's why we have an on-site pulmonologist and an on-site cardiologist that can do on-site pulmonary function tests and on-site cardiac echocardiography. It's based on the evidence, and as the evidence continues to evolve, we are very, very open, interested in, and have an eagle-eye focus on continuing to evolve our centers to make sure that we're meeting the needs as we further determine them of people with long COVID. You mentioned the example of pulmonary emboli. This is something that I looked into it, and we haven't in our system noticed of note anything that's different from what we're seeing nationally, but that's the type of thing where if it turns out that a patient suffering from long COVID, because as you shared earlier, the statistic of your risk for long COVID if you've been hospitalized is substantially higher than your risk of long COVID if you weren't hospitalized or if you were asymptomatic. Those types of things we'd want to build into our centers of excellence, which, and we are very capable of doing so. For example, as you visited with me, the center in Bushwick, we have a CT scanner and an MRI machine there. So it gives us, even going beyond pulmonary function tests for lungs, it gives us an ability to really do a lot more for our patients, depending for whatever symptoms they're having or whatever new conditions they might develop. Going back to some of your initial questions on what are we seeing in our system and how are we going to track that over time. Nationally, I just want to highlight a couple of statistics, and this is true for our system, I believe, as well as the rest of the country. Between 10 and 15% of people with that have COVID will go on to develop long COVID at the 4-week mark. The CDC says 13.3%. If you look at Nature or some of the other preeminent publications, it falls generally between 10 and 15%. Among hospitalized patients, it could be as high as triple that. So that's much higher for them. What we're beginning to see in our system is in my primary care practice in the Bronx, I'm now seeing more and more patients that have long COVID, of my patients, council member. And that bothers me. I care deeply about my patients, and I'm seeing more and more of them that I'm diagnosing with long COVID. In the past, one of the challenges has been I've diagnosed many of my patients with long COVID, But how I enter it into the electronic medical record, it hasn't kept up with what we're actually what the care that we're providing. There hasn't over the last several years been an ICD-10 code for long COVID. So where I may in the electronic medical record list shortness of breath, depression, and I'll write that it's due to long COVID. If you were trying to extract that from the medical record, it would be challenging. Now we have an ICD-10 code, so I'm able to actually, for my patients I'm diagnosing today or I'm continuing to treat today, I actually enter that into the electronic medical record. So moving forward, we're going to have a much more precise sense of what the true prevalence of long COVID is, in particular among our patients. Right now, I would believe that it's similar to what we're seeing nationally, so we should assume 10 to 15% of patients that have had COVID in the past will go on to develop long COVID, with the number dropping off at 60 and 90 days, which is encouraging. But my patients at the 4-week mark that are still having symptoms, many of them are terrified. Many of them are really afraid of what they're experiencing. They don't know what's going on. They don't know if it's related to COVID. I've had patients with hair loss. Is that related to COVID?
Yeah.
It is.
Some people.
For some people, thank you. And our ability as a system, we have to be there, knowing the prevalence of developing long COVID, knowing that if you've been hospitalized, it's much higher, knowing that we are continuing to find new symptoms like the pulmonary emboli that are likely associated with COVID. We need to be there to immediately be able to answer our patients' questions, to be able to address that. It's partly through our centers of excellence, but we're doing trainings for all of our doctors too, so that in my primary care practice in Morrisania, I can feel comfortable taking care of my patients there, similar to how our patients would receive excellent care at the centers of excellence that you visited. But I do want to make a final point related to, I think, the underlying intent of your questions, which is, given that we know how common long COVID is, and given that I am seeing more of it in my patients in the Bronx, and now that we have the ICD-10 code, we're going to have a precise sense moving forward of how many patients in our system truly have it. What keeps me up at night is all the patients that don't have me as their doctor, that haven't made it into one of our centers of excellence, or don't have a primary care doctor. I really believe that we need to have a laser focus on them, so the next time you ask me how many patients in our system have long COVID, I'm not just telling you about the patients that already have a primary care doctor today. I'm telling you about all of the New Yorkers that today are suffering in silence because they don't know what's going on, but they have long COVID, but they don't know how to get into some of the excellent care that we provide at our centers of excellence or the rest of our system, or centers of excellence across New York City. The way that we're going to solve that together is what you said earlier. Getting the word out about 212 COVID-19, getting the word, and having our aftercare program, which we're really ramping up now, call back everybody that's had COVID before. And if you're still having symptoms, we exist to help you, to bring you into care now. That's what's going to make a definable difference in New York City that no other city has.
I do appreciate you, but so you don't have no approximate data, how many patients that you've seen? Because since we laser focus on that in those Gotham clinic, so don't we have a number approximately how many they see in the Bronx and Bushwick or in Queens? No?
We have a back of the envelope, but what I'd rather give you, which we're happy to follow up with, is when we've used the new ICD-10 code, that's the way, because that's the diagnosis code. So as opposed to trying to make sense of our medical records before we had that code, be able to actually use that code so I could tell you this is the percent of people. Now that we have the code, that it's gone, that the federal code was created, we'll be able to do that hopefully in short order.
Okay. All right. Could we do more to inform COVID patients and those of high risk COVID? Could we?
Yes.
We could do more? Okay.
We could.
So what do you think we could do more?
I'd like to work together on that. I like the idea of working more with CBOs. We've started to do that through our T2 CBOs, which have been prolific in getting the word out about testing and vaccination efforts in our communities. And we have our NYCC CBOs as well, which have done a phenomenal job of bringing we now have more than 100,000 NYCC Care members in New York City, which, by the way, half of them are new to primary care, meaning they may not have seen a doctor in 40 years, which has been my experience in the Bronx. And by the way, NYCC Care members in New York City have twice the prevalence of diabetes as the general population. These are the people that it is critical we reach out to now, because they're at higher risk of developing long COVID. They're at higher risk of developing complications as well. So we need to get the word out to all of these groups of people. We will continue to work with CBOs, and I would welcome your and I know Councilmember Moya's recommendations on anything more we can do with community-based organizations. It's been one of our secrets to success, or key ingredients to success in New York City, and other methods including paid media, and trying to get the word out with meetings like this, where we can share 212 COVID-19 is the one number you need to remember that can connect you to everything. But I would really welcome more of your recommendations about what more we can do, because we're only going to do as good of a job as the number of New Yorkers that we inform about these unique efforts that we have in New York City.
Okay. Now, before I get any further, I want to acknowledge CM Brennan. Thank you. And Council Member Charles Barron had called that he had an emergency and get stuck in his community. One other, visiting nurse services, I know, not giving a prompt to visiting nurse services. I know they do home care and all other home care agencies. I'm sure, because I used to be a home care nurse.
Yeah.
Maybe we can share data to see how many people are staying at home so that we can reach, because especially if they're in Bushwick area where you have the facilities that providing the care.
That's a great idea.
Some long COVID issues can be managed with existing medication or treatments for symptoms like headaches or gastrointestinal problems. Physical therapy and cognitive rehab, including approaches often used for patients who have experienced stroke or brain injuries, can also be helpful over time. What sort of services has H&H provided?
So the way that we constructed our centers of excellence, using the examples just like you did, is we looked at all of the lingering symptoms or new symptoms that is the constellation we refer to as long COVID, and we built the most common ones into our centers of excellence. So the most common, and just to go back for a moment, the most common symptoms associated with long COVID are things like fatigue, as you mentioned, brain fog, shortness of breath, cardiac issues, and very importantly, depression and anxiety, which cannot be overlooked or missed as we think about long COVID. So we made sure to have all of those services on site at our clinics. And one of the things that we're going to be doing over time, well, two things rather. One is we're going to see among our New York City patients which services they really need. And that's going to help us to further refine our model. And then the other is, and this is something you brought up earlier, the pulmonary embolism thought. So as we learn as a scientific community, as multiple national studies are ongoing, what other symptoms may be associated with long COVID, we want to make sure that we can build access to any treatment that our patients may need into our centers of excellence. And I just want to make a plug one more time, and Celia is welcome to, if you want to jump in on this, is that's our approach to our centers, and I really do believe that the other centers of excellence that have come up across New York City, now we were fast out of the gates, but since then many others have constructed similar models that they're looking to do a similar thing.
Yes, thanks, Ted. It's true that there are other health systems in New York City that are also developing centers of excellence and other models to help take care of people that have post-COVID conditions. That's something that the health department is making available for everyone on our website, so people can find out about long COVID and how they can access care, including at the H&H centers of excellence.
Talking about the subspecialties, because I know you don't have all the subspecialties in every facility. So do you have a referral base that where you send patients to?
Yeah, so the way that we've constructed our centers of excellence is we have the most commonly needed subspecialties. So again, when you were at Tremont, you may have met the on-site cardiologist and pulmonologist, the pulmonary function tester in the pulmonologist room. So, and as we have further needs that we are able to determine over time as the research continues to evolve, we will place whatever other subspecialties we need to on-site to make sure that people have immediate access. For anything that we don't have on sites, perhaps some of the less common symptoms, but again, equally important for us to address for people, we have a referral network among our hospitals so that you can receive any care that you might need for any of those symptoms as well.
If I recall, I asked some question about do you have nephrologists? I don't think you have nephrologists or doing dialysis in the centers, right? You don't have that.
Correct. So to separate them out, so for nephrology, if we believe you're having a nephrology condition that could be associated with COVID, we have a referral network set up to our local hospitals for that specifically too. For hemodialysis, we have hemodialysis centers that we would refer you to. So a bit of a different approach, but both of those are available now.
Don't forget, I'm a nurse, and I used to work on both floors for hematology and follow-up.
Yeah.
Do you follow up after you refer them so they can come back? Or you have the referral? How is the referral like coming back to the clinic?
That's a good question. So let me actually back up and maybe share a little more about with aftercare, how we're doing the outreach for both outbound
The
calls
return.
and inbound. Yeah, and then the return piece too. So the way that we started off with aftercare, and actually let me just premise by saying, after I share with you what we're doing here, I want to also make the point, this is an evolving program too. We're the only city in the country I'm familiar with that has a program like this that's focused on connecting people with long COVID to resources proactively. But if there's more that we can do, this is the time to let us know. We're very, very open to continuing to craft our model together. That includes with how we get the word out, including through community-based organizations. So let me explain to you a little bit of the backdrop here, and then I'll get to answer your question. So the way that we started the aftercare program is we looked at patients in particular at higher risk, so patients in disproportionately affected communities, and that were still having symptoms at the end of their monitoring period, that because we monitored you through test and trace, and then we sent text messages, 334,000 in total now, starting to them. Because the people at highest risk for developing long COVID are those that still, of course, had a more severe COVID, as evidenced by still having symptoms at the end of their monitoring or infectious period. We then started to make outbound phone calls, and we started to receive inbound phone calls. So right now, if you call 212 COVID-19, you press 4, you'll be put through, somebody will pick up the phone. And that'll be one of our aftercare navigators, and we complete the phone referral that way. But moving forward, what we want to do with the aftercare program, and this is something I feel very, very passionately about, is we want to make it a very, very proactive outreach-based program where we're going through the lists of people that we reached before. Before Omicron, we reached 90% of all New Yorkers for contact tracing that had COVID. 90%, more than any other jurisdiction in the whole country by a long shot. We reached you before, that tells me one thing, we can reach you again. And that's what aftercare is going to start by doing, is really proactively reaching out to New Yorkers again. We have a winning formula for reaching people. So we want to be able to reach New Yorkers. And again, if you're at home suffering in silence, you have confusing symptoms, or you need a community because you don't really understand what's happening, what's going on around you, or maybe you need specific financial supports, we can do all of that for you. So what we want to do is be very proactive in how we reach out to people. Now, to your question, so what if you need medical care at a center of excellence? So with aftercare, if we've reached you before and we refer you to one of our centers of excellence, we facilitate you making an appointment there. If we didn't reach you, or we tried to reach you before and you were in that initial tranche, we're going to reach back out to you now to see how you're doing. And if you're still having symptoms, we're going to, again, talk to you about medical care, talk to you about whatever else you may need. But our goal is, specific to the centers of excellence, for instance, anybody that needs care in one of our centers of excellence, so anybody that needs medical care for long COVID, there's going to be multiple bites at the apple. And our goal is to make sure that we offer you the excellent medical care that we've worked hard to be able to build.
Thank you. If we're in the height of the pandemic, you will see the room packed, right? So now, since we don't have health, it's when the crisis, the pandemic or epidemic, you find a lot of people interested. So thank you for continuing understanding that we have to reach out to folks.
Right.
Because once they're not going through the process, they tend to forget. And then long COVID is important because the percentage that having the long COVID is not all the population. So the one that I have not experiencing the long COVID, forget about COVID when they get COVID.
Yep.
And even in the panel, is it me, myself, and the CM Moya, we're very much interested in the health, because once you understand health, you know that you have to keep your eye on it. So thank you.
Agreed.
Are those seeking services also connected to mental health services?
Absolutely. I would never have it any other way. So to walk through what that means is we use the collaborative care model. So if you're coming in and you're evaluated by a primary care clinician like myself that's an expert in long COVID, and you have mental health or behavioral health, meaning substance abuse too, needs, we refer you to our collaborative care model, which is social work based with supervision by psychiatry, get you immediate access. I also want to make the point, though, that with long COVID, that's the majority of issues are around depression, anxiety, things like that, which our collaborative care model is tried and true, evidence-based. My mom's a social worker, so I'm a little bit biased here, but I think it's an excellent way to provide behavioral health care to people. If you're having some of the other less common symptoms of long COVID that are in the behavioral health spectrum, like we are unfortunately seeing a little bit more like intermittent psychosis for patients that have been in the ICU, things like that. We do have the ability, that goes beyond the collaborative care model. So in that case, we would refer you directly to a psychiatrist.
Thank you. What is the age range of those that you serve? Or are you seeing the long COVID patients who are children?
We are seeing everybody, and not only patients with long COVID. So at our centers of excellence, we treat everybody without exception. For long COVID specifically, we will treat children with long COVID or adults with long COVID. For people that come to us that are family members that have never had COVID, we'll treat them too. That's why we have on-site mammography, DEXA scans, United States Preventive Service Task Force recommended studies, things like that, x-rays. We have all of the resources to provide you comprehensive primary care, whether you've had COVID, long COVID, or not. Even if you have COVID when you come and see us, as you remember, we have negative pressure rooms so that you could see a primary care clinician
Yeah, I love those
safely.
rooms, by the way.
And, sorry, I have to brag for a second.
You can brag when you can back it up. That's what Muhammad Ali said.
I'll try. Even for dental care, because one of the things is we want to make sure that we can provide all care to everybody at all times. Dental care is one of the risky types of care to provide because your mouth is open. So if you have COVID, you could be at risk for transmitting it, of course. But we developed a very sophisticated ventilation system in the dental rooms so that if you have a dental emergency, if you have long COVID, we'll treat you. No COVID will treat you. Or if you have COVID, we'll be able to treat you safely there as well. So truly our sites are based on turning nobody away and seeing everybody without exception. And I was just informed by my colleague, Laura Atlas, that another interesting fact about our centers of excellence in terms of who's coming so far is that the majority of people, English is not their preferred language. We are making inroads in terms of getting through to people from diverse communities. The 3 top languages are Spanish, Bengali, and Polish so far.
What are the most common attribute of those with long COVID?
So what we're seeing so far in terms of the most common symptoms are consistent with what we're seeing across the country. I'll share what we're seeing at our sites, and I'll turn to Celia if you want to paint more of the full picture about New York City and what we're seeing. So brain fog and fatigue is very common, shortness of breath is very common, and mental health.
Mental health.
Yes.
That's what I didn't think okay.
That's one of the top ones we're seeing in our sites. Do you want to share any more about it?
Go ahead.
Oh, sure.
Go ahead.
Thanks. So, I think Ted is right to say that the symptoms that you're seeing are very consistent with what has been seen in studies done nationally. The New York City Health Department isn't tracking every case of long COVID. There's no standard definition, so it's really hard to measure this at a citywide level. What we have been doing is since February 2021, we collect data that is self-reported as part of our population health surveys that relate to people's experience with COVID and their symptoms that might extend after they have COVID. And from those surveys, our data is suggesting that up to 30% of people who have had COVID-19 may be experiencing symptoms 4 or more weeks later. So those are all people who may have long COVID. And I think some of the issues that are being raised during this hearing about access to care and how important it is for everyone is really the most critical takeaway point.
Thank you. I'm going to pass it on to Chair Moyer because he has some questions, so I can take a break and I come back.
Thank you, Chair Narcisse. Thank you. Thank you, Dr. Long. So I want to switch over to the T2 Aftercare program, if we could.
Please.
So can you please outline the services that are offered by T2 Aftercare the program, and how many people have contacted the T2 seeking assistance with long COVID-related symptoms or other issues related to living with long-term COVID?
Yeah, good question. So, and I appreciate your question because I think it's important. Excuse me, just this. It is important that one of the unique things about our aftercare program is we've constructed it to not just be focused on medical care, but medical care, being physical health and mental health, creating a sense of community. I mean, my patients that have long COVID, they're still not knowing what this means for them. They need a lot of support, more than I can provide to them oftentimes in my one visit with them. And we've created that. The Body Politic is an organization that helps people to know there is a community of people experiencing similar things. We recently had a long COVID symposium as well, a full-day event, where we invited patients. They were the first speakers, patients. It always should be that way. And one of the things that they brought up is really the need for community around what they're experiencing. That was the type of support that they told us they needed. So that's a very important part of the program. And then the financial part is very important to us as well. If you're going to be evicted from your home because you have long COVID and it affects your ability to work or other things like that, we'll work it through with you. Our navigators are experts in working things like this through. So between the financial piece, the community-based support piece, and the physical and mental health piece, that is what the aftercare program is. The specific number you asked about is how many people have reached out to us. That's more than 50,000 have called our hotline, press the press off button, and been connected to one of our aftercare navigators. In addition to those more than 50,000 people that have reached out to us, I think showing that there is that people are beginning to at least know about the resources that we have through 212 COVID-19 with respect to long COVID. But in addition to that number, we've proactively reached out to 334,000 people via text and more than 114,000 people via completing phone-based referrals with them. So these are numbers I want to see them all go up, up, up. But in particular, the one of people reaching out to us, I think our ability to work together with you all and with community-based organizations would be very helpful there too.
So yeah, well, I'll get to the community-based organizations soon. But so just so I'm hearing correct, 50,000 reached out to the hotline.
Yes.
Out of those 50,000, how many people received services? Did you say it was 114? Oh,
No.
Sorry.
Sorry.
I just want to make sure I have it.
We've had 114,000 people that have completed referrals by phone.
Got
What
it.
that means is that you called and said, I need support from other people experiencing long COVID. Place a referral for our community-based support. I'm going to be evicted. Place a referral for that. So when we complete those referrals, so not just, I called and hung up the phone.
Right.
That wouldn't count as a completed referral.
Right.
That's happened 114,000 times. Among people that called us, that's 50,000 people picked up the phone and proactively called us through 212 COVID-19. We didn't call you, you called us. So that's a subset, if you will, of the completed referrals.
So just so I'm clear, how many people actually received services?
So the 114,000
Got it.
would be
Okay.
the complete referrals.
Perfect.
Yeah.
Thank you. And staying on that, like what sort of assistance do folks with long COVID need when it comes to doing daily tasks of cleaning, grocery shopping, etc.?
Yeah, I'm gonna, if I may, I'm going to intentionally evade your question because to make a point, there's no one
Gotcha.
thing that people with sorry.
Yeah, I got what you're saying.
There's no one thing that people need, and that's the reason why we created the Aftercare Navigator role. We could have set up a hotline to connect you to our Center of Excellence, where you talk to a primary care doctor like me. But honestly, a lot of people, what they need is not to talk to a primary care doctor like me. I'm not as helpful in navigating if you're being evicted from your apartment, or if you're having other financial stress, or you need to be connected to a community group that can embrace what you're experiencing. Our aftercare navigators are multifaceted, and they can do whatever you're experiencing. They'll work it through with you. So we intentionally wanted to keep our model very broad, not wanting to try to say there's only one thing people are going to have a problem with respect to long COVID.
Are those seeking services also connected to mental health services as well? I know you were talking about that earlier, but
Absolutely.
When it comes to this, I just wanted to.
And so can I actually, they're not only are they, but they're connected in two important ways. One is if you're referred to, let's say, to one of our centers of excellence and you're seeing a primary care doctor like me, we'll assess you and we'll connect you to the specific mental health services that you need. If it's anxiety and depression, it's our collaborative care model. If it's intermittent psychosis, it's a virtual psychiatrist. However, when you're on the phone with our aftercare navigators, you don't even need to wait till that step necessarily to be connected. They can connect you immediately to NYC Well, which is a 24/7 service that's offered to New Yorkers for mental health needs. So that's part of the reason why our aftercare navigators, it's not a one-size-fits-all model. We want to make sure that we sort of meet you where you are. Some patients prefer to talk to a doctor first and wait. Some patients want to talk to somebody right then and there. Either way, we'll meet you where you are.
So I was going to ask you this, but I'm going to ask you this, and then I just want to go back to the 50,000 calls that were made.
Sure.
Because what are the most common languages spoken by those seeking assistance with long COVID, and how does language translation work when one contacts T2 Aftercare?
So when you call the COVID hotline, we immediately put up the most common languages. So you can call after this meeting 212 COVID-19, and if you don't press anything, you'll be the same message will be delivered to you in multiple languages. So you wait for your language, and then you'll press that button, and then you'll be taken through the phone tree in your language of choice. if you speak a less common language or dialect, we then do use our interpretation service at New York City Health and Hospitals. So that is what I use in my primary care practice. As you know, there's hundreds of languages and dialects, including I have one patient that I love to talk about, which I won't belabor, that speaks a very rare African dialect, and she always smiles when she sees me because I'm one of the only people that she can talk to in New York City, because when she sees me, she knows that my interpreter service can connect her to her language.
So that's what I was trying to get at now. Was the 50,000 ever broken down into languages, the different languages that were called, or different ethnicities that you were tracking in terms of those that actually picked up the phone and called on their own?
That's a great question. I don't have that piece of data off the top of my head, but I'd be happy to look into it and circle back with you.
Okay, that'd be great. Just because, I'd like to see, is it reaching the immigrant population that they're actually doing this on their own, or is it that there's not enough, that we have to do more in order to get them the information to be able to know that this is a place where they can go and get all these services? So it'd be great if we can work on that.
Yeah, totally. And the one number again I have, which is sort of gets at it a little bit, is at the end of the end stage outcome there is that over half of the patients that make it into our centers of excellence, English is not their preferred language. And again, I gave you some of the more common ones, but I really do believe, I think you're asking the right question, because we set up this phone line to be easy to remember and usable for anybody across New York City. So I think your question is right on. So I look forward to following up with you.
Thank you, Doctor. With the Test and Trace aftercare program, aftercare program supports New Yorkers with long COVID by connecting them with the resources that meet their health and social needs. What sort of resources does a program connect folks to? What is the turnaround time of receiving services? What happens if it's an emergency situation? And do we formally contract with any CBOs to do this work?
Yes. So two parts to your question.
Yeah.
So in terms of how we think about timeliness with services, this really does get back to how we wanted to have our aftercare navigators be equipped to deal with every situation uniquely, not have an average. Every time somebody calls about X, it's a 2-week wait. That doesn't make sense, because some people need it tomorrow, but some people need it in a month. So our aftercare navigators, when they're on the phone with you, they'll figure out together, let's say if it's reaching out to HRA about a housing issue, the acuity of your specific need is what they'll take into account as they make a plan with you and complete that referral.
I see.
So when we say completed referrals, that means we made a plan that together with you that meets your needs.
Right.
Second part of your question was...
What happens in an emergency situation?
Oh, in CBOs we're using.
CBOs, yeah. What do we formally contract with any CBOs to do this work?
Yeah, so the actual aftercare navigators are from CBOs. So the actual aftercare navigators are from the Chinese American Planning Council, Bronx Works, and CUNY. So we intentionally chose to work with CBOs to actually give us the staff that constitutes our aftercare navigators, believing that they're the right people to get through to our communities and to gain the trust of our community members that are making the inbound call. They're making calls, outbound or inbound.
Those 3 CBOs?
Those 3 CBOs are the actual ones that furnish the aftercare navigators.
Okay.
We work with many other CBOs in terms of getting the word out about the program. And
Okay. Thank you for that. Just a couple more questions.
Yeah.
That deal with equity and stigma.
Yeah.
Those, we've seen that those with long COVID have experienced or may have experienced stigma and kind of be dismissed. They have difficulty in explaining or proving their symptoms and may lack the definitive answers as to why they're experiencing this. The CDC points out people with long COVID may develop or continue to have symptoms that are hard to explain and manage, while clinical evaluations and results of routine blood work, chest x-rays, and echocardiograms may be normal. We've heard of such instances. Have you heard of such instances with patients? And what do you recommend these patients do when they experience that type of stigma?
So I'll start, and then I'd love to have Dr. Quinn weigh in. I just want to start by saying I completely agree with you. This is a huge problem. That stigma is directly causing people to suffer in silence at home today as we sit here. There's people with long COVID that don't know if it's long COVID, if it's just them, if it'll go away on its own, and they're scared. I've had patients, again, with their hair falling out. And it is critical that we work together to get the word out about what we've created in New York City, both by creating a great inbound way for people reaching out to us when they know the number to call, but for us, equally importantly, getting the word out to them, because as as the chair stated earlier, if we're looking around the room today, it does look different than at the height of COVID. That's why we need to be calling people on an outbound basis to engage them where they are, to help to fight back on the stigma that's causing them, that literally is causing them to suffer in silence today. So that work is incredibly important. That is why we exist for that as the aftercare program. But I'll turn to Dr. Quinn to share more.
Yeah, thank you. I also really agree. This is a really important piece of what we're doing. We are doing a lot of work to educate providers in New York City about long COVID, how to recognize it, how to listen to patients, how to document it so that we can have better information about what's going on. So to that end, the health department did release a Dear Colleague letter that went to tens of thousands of providers in New York City just earlier this month that really emphasizes some of those points that you were just bringing up. And then I think Dr. Long mentioned earlier the symposium that H&H and the health department co-hosted earlier this month. And starting with the voices of the patients, I agree, was really powerful. And we got that feedback from providers who are attending that symposium. So I think this is a really important role of the health department to continue making sure that as information comes out about this emerging condition, that we're sharing that with providers, making sure that they know how to work up a patient that might be experiencing long COVID and where to refer them for additional resources.
Thank you. So we know that such stigma can intersect with the bias with regards to bias that is faced by Black patients and other patients of color, older folks, immigrants, people living with disabilities, those with limited English proficiency, members of the LGBTQ community, and others. How is this addressed by the H&H staff?
Yeah, that's a great question. I think the way that we're addressing this is through working with community-based organizations. So, for example, the community-based organizations where our aftercare navigators come from, our aftercare navigators, 74% of them speak more than one language. Some speak multiple languages, which is something that you get when you work with community-based organizations. You mentioned also immigrants, so our NYC Care CBOs have been a critical piece here as the trusted messengers in many of our communities. Immigrants can oftentimes be the people that would suffer the most from stigma because they already have barriers in front of them about seeking medical care. So we want to tear all of those barriers down with trusted messengers, and that's why for specifically our NYC Care CBOs, this has been, but will become even more important moving forward as what we need to do to help New Yorkers, meeting them where they are with where their needs are today.
Right. Just two more questions, and
Yeah.
I'll turn it back to Chair Narcisse. Given that the Black, Latino, New Yorkers, immigrants, older adults, and other communities were disproportionately impacted by COVID towards the beginning of the pandemic, when there was no vaccines available, do you find that these populations are also disproportionately impacted by long COVID?
Yeah, I can start with that one, and then would be interesting to hear what H&H's experience with this has been. It's unfortunately hard to know because, like I mentioned earlier, the way that we find out about long COVID has been mainly for the health department through our population-based surveys. There's not a standard definition. Until recently, there wasn't an ICD-10 code. It's very difficult to get surveillance level data about this particular condition. It would not surprise me that people who were more disproportionately impacted by COVID have a higher burden of long COVID. Unfortunately, some of those populations also have a lot of difficulty accessing care and might not be diagnosed with long COVID. So those are all things that impact our ability to have really good information about what's going on at the patient level.
And I would add, I'll go back to this one statistic I shared earlier. The fact that at our centers of excellence today, more than half of the patients, English is not their preferred language, I think does speak to the need of people from our diverse communities that need help, especially with respect to long COVID. So, with respect to our centers of excellence, we built them in areas that were disproportionately impacted for the initial tranche of 3. We're going to continue to provide those services and seek to expand services beyond that as well as we gain better data. But I think that we have enough evidence, we have more than enough evidence to have this be a call to action, to have our outreach and our focus really be on our other neighborhoods that were disproportionately affected as well across New York City. Right. How we make phone calls, how we're getting the 212 COVID-19 number out, how we're working with CBOs. Those are things that we all need to focus on now for the reasons that you were just articulating.
Right, and I think that that's kind of the key thing we saw. Look, I represent the epicenter of this, and we know how slow it was to get that information. But we also saw that most immigrant New Yorkers are very reluctant or don't have the time and the luxury to take a day off. They traditionally don't see a doctor on a regular basis. So with these diagnoses that they will get, as we were talking about all of this, it's so critical that there's a real investment that's made in those communities that really have a deep-rooted structure here. We've seen that faith-based organizations have proven to be a key factor in how we got that population to get tested, get the vaccine, things like that. Is that model still there, that you are actively engaging with those key partners to get this information out to folks?
Yeah, that's a great question. I'll start and then I'll turn to Dr. Quinn. If I was to say what one of the definably different things in New York City has been compared to other places that's enabled us to have a higher per capita testing rate than almost any other country in the world, I would say it's our ability to keep things local and to work with local community-based organizations. I truly believe that. For example, home tests are something that I believe in. I want to have in my ideal world, every New Yorker would have a home test, at least one home test at home. So if you aren't feeling well, maybe even a little bit off, before you go and see your grandmother or before you go to work that day, you'll be empowered to know you can test yourself for COVID in a matter of minutes, whether you test positive for COVID. That's what I want for every New Yorker. But in terms of doing that, to your point, there's a variety of barriers. So right now we're working with 858, 858, big number, of community-based organizations and houses of worship across New York City to distribute these home tests. I think it's an effective way. We've distributed more than 33 million home tests to date as a city. But what we can do now, to your point, and what I'd love to get more of your thoughts on, honestly, is how should we be communicating with these new 858 CBOs and houses of worship about 212 COVID-19, about aftercare? We've started something with things like home tests and with our NYC Care CBOs in the past, but I think we're at the point now where I really want to continue to build off of all of that. Certainly, the very specific point you're bringing around churches, around houses of worship, they've been a core partner in our ability to get home tests out. I would love for them to be a core partner in our ability to have them as trusted messengers talk to their congregations and members about long COVID to help to tear down that stigma.
Right, and we'll love to have that conversation, because if we do it now, we'll be here till like 10 o'clock at night.
Yes, we will.
I'm sorry.
No, I just wanted to add that, the health department also has public health core, community-based organizations, faith-based organizations, community-based organizations that we're also very similar set of activities that is also tightly coordinated with H&H. So we're all happy to be part of that conversation.
Great. And this is the last question because it's the same thing, but with New York Cares, right? With H&H and the enrollees, have you seen that there's been people that are coming in with long-term COVID symptoms?
Good question. So actually, over the weekend, I touched base with Dr. Jimenez, our executive director of NYC Care, and we are starting to see patients, NYC Care members with long COVID, either engaged with Care Now or coming in for care. I expect those numbers to only go up, and I mean, I hate to say it this way, but I want those numbers to go up. Long COVID exists whether or not we're detecting it. So the more those numbers go up, the more people we're going to be able to help. I will tell you, in my practice in the Bronx, again, I know an N of 1, but I have a lot of NYC Care patients. And
Are you taking any new patients, doctor?
Yes, I absolutely am. I have stories about that too, but I am seeing more long COVID among my patients, including my NYC Care patients. And I think, from my perspective, one of the interesting things I see is I ask my patients, especially my new patients, why today? Why today have you sought medical care, especially if you haven't seen a doctor in 10, 20 years? One of the things I'm hearing more and more now from my patients is, I had a great experience with test and trace getting tested, or I had a great experience getting vaccinated. I previously knew that there were these city sites, but I didn't really think too much of it, and I had a good experience, so I figured I would reach out now because either I'm having a problem or I'm not having a problem and I want to talk about preventive care. But I think that we have an opportunity now, all of that's to say, through programs like Aftercare to build on what we've started. And I think I would measure our success as our effectiveness of getting the word out about what we've built through programs like Aftercare, but not just Aftercare, through our community-based organizations. We're there. I think we've done a great job over the last couple of years in helping a lot of New Yorkers. Now we need to get them all to be aware of long COVID and to know how to get into care.
Great. Thank you. Thank you, Dr. Long. Thank you, Dr. Quinn. I'd like to now turn it back over to Chair Narcisse. Thank you.
Thank you, Chair Moya. And one other thing I can tell you, I'm so happy that we have a hearing with a real doctor that's practicing. I hate talking to, I don't want to go there. So when you're talking about
names are being
health
mentioned.
and you're talking about somebody that don't have no business in. Anyway, thank you so much. Now I want to acknowledge our CM that just joined us, CM Brewer. Thank you. And we have some folks submitting written testimony online, and we thank them, and we're going to let them know that we will go through everything that submitted. So like I said before, when it's not height of the pandemic, you're talking about COVID, not many people are watching. And for those that take the time to do that and those that in the room, thank you. Thank you. I really appreciate you. Dr. Long, there's some question I had for you here.
Yeah.
Oh, with the CBOs, piggyback on what CM Moya just was talking about, what is the process that you use to determine who get the contract for after care for long COVID?
Great question. So with how we work with CBOs, there's the piece of how we work with CBOs. I'm going to invoke Dr. Quinn in a moment. How we work with CBOs to get the word out about aftercare, and there's the piece of the CBOs that actually provide for us the actual aftercare navigators. So we've been working with the Chinese American Planning Council, Bronx Works, and CUNY for a while. Actually, their previous role was to provide for us our resource navigators. So in New York City, we've always had a unique way of connecting people to whatever resources you might need if you have COVID or you've been exposed. We've had our free hotel program. We've delivered more than 2 million free meals to people. One of the things I'm really proud of, I hate to belabor the point, but I am so proud of this, I will tell a quick story if I may, is I've had a lot of my patients over the years tell me, that when they have COVID, they have to go to work the next day. They're oftentimes undocumented immigrants, and they have to make the choice of, do I go to work infectious to support my family, which is the wrong public health answer, or do I stay home, not get paid, but I don't qualify for paid sick leave, and jeopardize my family's financial future, potentially getting evicted? That's a false choice that nobody in this world should ever have to make. Now, listening to my patients, that actually triggered a thought that we had, which was that we, through our resource navigators, created a direct cash assistance program, which I'm proud in New York City we had. I don't know if any other places had this, where we were able to pay you to not have to make that false choice, because it's not a choice choosing between your family getting evicted and doing the right thing for public health. So we enabled New Yorkers to make what is the only choice, the right choice, to stay home but not lose their apartment for their family. So things like that, our resource navigators for the last 2 years have worked with people on. So building off of their ability to engage with people, those same CBOs with a lot of the same navigators themselves are switching into this new role. These are the world experts, both these CBOs and the navigators, in talking to you about meeting you where you are, to Councilmember Moya's earlier point, about figuring out what your unique needs are and formulating a plan with you. Before, it was formulating a plan if you had COVID. Now it's formulating a plan if you have long COVID. But that's how we work with these CBOs, and that's where these navigators come from. They're very, very good at what they do. For the question of the other CBOs we work with, this is where I'll turn to Dr. Quinn in a moment. We have a couple of different buckets of CBOs that we work with in terms of getting the word out about what we're doing and acting as our trusted messengers. We have our T2 CBOs. We have our NYC Care CBOs. We have the new network we built getting home tests out. And I'll turn to Dr. Quinn to talk about the other CBO relationships that DOHH has.
Right. So specific to COVID, we have a lot of the public health core CBOs are focused on COVID, long COVID, vaccination, testing, a lot of these topics at the moment. But there are also CBOs that have a lot of experience in their communities working on a number of different health topics and public health topics. So it really runs the gamut.
Thank you. Before I turn it to our colleague that just came in, Gail Brewer, that have question, I have a couple of questions for you. Those with long COVID may experience stigma, and we talked about the stigma before, have difficulty explaining or providing their symptoms, and they may lack definitive answers as to why they are experiencing the long-term effects they have. As the CDC points out, people with long COVID may develop and continue to have symptoms that are hard to explain and manage, while clinical evaluation and results of routine blood tests, chest x-ray, and electrocardiogram may be normal. Have you heard of such instances from patients?
Too often that's happening, and that's why I think it's important to have a program like Aftercare where you may have symptoms that may be having different meanings in your life. They may be confusing to you. They may be confusing to your doctor. And what you need sometimes may be to have a doctor that understands, or maybe it's not a doctor at all that you need. But Aftercare, the reason we've structured it as we have is to be able to help meet you wherever you are. That's, I think, been one of our most successful mantras with COVID is we have to meet everybody where they uniquely are. So whatever needs you have, our Aftercare navigators specialize in figuring them out with you. To your point, though, we are also hearing, and this was brought up in the COVID symposium, that there are doctors out there that are less familiar with long COVID than other doctors are. That's why Dr. Quinn, I'll turn to her in a moment, has sent out the provider letter, and we're thinking together about how we can make sure that we're able to have all doctors feel comfortable treating patients with long COVID, or, honestly, knowing when to say, I don't know.
Yeah, I don't have a lot to add, but we would encourage people to read the Dear Colleague letter that was sent on June 7th, because I think it actually does a really nice job of explaining why it's important for providers when they're evaluating any symptom to really listen to their patients without stigma, to try to search answers even when some of those might not be easily findable, given this is an emerging condition, and to think of long COVID when they're faced with a difficult diagnostic challenge.
Do you keep on updating your website to additional symptoms that come out? Because alopecia, I didn't know that alopecia was part of it, which is hair loss, sorry. I didn't know that it was part of COVID until that I started talking to a few folks, and they told me, yes, they suffer alopecia due to COVID because they never had alopecia before.
Yeah, there's such a wide variety of symptoms that can be, and we are learning may be associated with having had COVID-19. So we do try to keep our website as up to date as possible with the emerging science. But I think the message that we're trying to get across to providers is to think long COVID for any really wide range of symptoms. We don't want people to close off their mind to this possibility based on the symptoms that they're looking at, because we really don't understand what is the underlying cause of the symptoms that are associated with long COVID yet. And so that's why there's such a wide variety of conditions that could be associated.
So definitely we have to keep on talking about it as we go along. Like I said, I don't think COVID-19 gonna leave us anytime soon. So we have to be alert and focused. And thank you for, things that work that you're doing. Thank you. Now I'm gonna pass it on to Council Member Brewer because she has a question.
Thank you very much. I think if all the doctors were like you, we wouldn't have a healthcare crisis. So I appreciate it, but they're not. I can tell you that from personal experience. I'm more interested in if there is data on the housing and the job issues. And I don't know if that's something that you collect. I'm the author of the Open Data Bill, and I'm very data oriented. So because goodness knows you're doing the best you can on the healthcare, but housing and jobs are a whole other world. So with your CBOs, your 3 or your larger universe, do you keep track of those? I call them constituent issues, but there's a better term.
Yeah, I'll start and then I'll turn to Dr. Quinn too. So for aftercare, when we're talking with you about what your needs are, we absolutely do. So I can share the data with you, and some of it is on our website as well. But we'll send you a note to give it to you directly, because what we do is we walk through. If you're having economic issues, is it related to X or Y? Is it housing?
Yeah, but they're not so easy to solve. That's why I'm asking. about
Yeah. No, totally.
Okay, so are you able to, what I want to do is see them, are they solvable? We don't want anybody to end up homeless, we don't want anybody to end up jobless, and none of that should be happening. Now, if it's not happening at all, and all 100% of your patients are housed and job, fine, but I think that would be something to look at, unless you have already.
No, I think the data we have shows that it is an important problem. The data we have agrees with you. Specifically with respect to housing, our aftercare navigators can connect you to HRA, can figure out if there's anything
That
that can
doesn't,
be done.
I won't use a bad word.
Please.
Okay. That doesn't do any good, just so you know. Okay.
Well, and actually, on that point, if I may, again,
One shot and some money, but it doesn't keep you in your home forever. Go ahead.
if there's more our aftercare navigators can do, we'd be happy maybe offline we could share with you.
Even I am the best aftercare navigator around. Okay, there's nothing I can't do. I can get you $29,000 for a one shot, and I can get you all the money, but it still doesn't solve the overall problem if you can't pay the rent in the future, right? So without getting into all the specifics, so that's why I'd like to know whether what the job and housing situation is, just to see the list and whether they're actually working or not.
We'll share data.
Just because you're a navigator doesn't mean you can solve the problem.
Yeah, agree, and we will share the data with you.
Okay. Second, in terms of, yes, everybody had a great experience with the free vaccinations and so on and so forth. So we do need to build on that. So the question I have is, I know you talked about it, but is that something that, as a result of this collaboration, coordination, which is not normal for New York City, as you know, then I've been doing this a long time. Then what are we doing to see, because your patients appreciated it, the city appreciated it. Do we have, I know all about, you have to, HRSA, obviously you don't share information because that's not appropriate. I got that. But do we know all the pharmacies that have been participating? Do we know who's looking to see how do we solve this healthcare desert problem where there's nobody taking care of a community in terms of healthcare? And people found the pharmacies, they found the places where they were. I know I did a whole lot of, finding a barbershop that would do something. That's what we did. Is somebody looking at all that to see how we need to replicate that? If Mrs. Jones went to the pharmacy, then she perhaps would go back if there was something there for her to go back to. Because people are not going to go to the health centers necessarily. How are we thinking about, in other words, how can we change the quality and the outreach of healthcare in the future? I know you're thinking that way, but I just want to know specifically.
Well, I'll start and I'll turn to Dr. Quinn. I think one of the things that is very important to me, again, as a primary care doctor, is thinking about what we've done that's been successful during COVID and bridging that into being a permanent part of our healthcare system.
Correct.
So, for example, our Street Health Outreach and Wellness Unit program, or SHOW program, of which I know you're familiar with. Yep. That's an example of why did we start that? Because homeless people living on the street weren't getting vaccinated and they were at risk, and we needed to help them. Yep. Figured out the best way to help them is to figure out what they needed. Maybe it's food, maybe it's treating their wound, and then they're willing to get vaccinated. That's so successful as a mantra, though, that program's going nowhere, and I'm even actually expanding that now. We have more units now than we did 6 months ago. So that's one thing that we want to do to keep going. It's specifically with respect to vaccines and pharmacies and things like that. One of the things I've also learned through COVID that is something I want to continue to build is you really have to meet people where they are. And I think our mobile infrastructure that we've built has been our way of achieving equity there, and has been one of our most successful elements, both for testing, vaccinations, and for other things in the future. And we should think about what those things should be. But I talk a lot. But I'm very interested in thinking together too, Councilmember Brewer, about how we can take more of what we've done with COVID that's been successful, especially from your perspective, and continue to grow it. Community health workers that were former contact tracers is another example.
Yeah, because what happens is you go back to the way we were, and that group still gets continually underserved. Go ahead, Dr. King.
Yeah, I think Dr. Long gave some really excellent examples. I would also add that we really built on our relationships with our community-based organizations, making them part of the public health corps, bringing them closer into some of the programs that the health department has around a range of different, conditions. And so that is part of what we're doing to help build trust with the community, to help facilitate that connection to care and connection into the healthcare delivery system.
Are they being funded for this? I know the three that you mentioned are, but the other ones are partners, sort of. Are they being funded? In other words, I think about the 9/11 fund, right? Successful, different group of people, not so many languages, not so challenging because people do know about it. I spent hours as borough president getting more people to participate, but it's well known. So the question is, we're working with these CBOs, but they don't survive on air. So do we need a new fund, for lack of a better word, that would help them get funded to do this work? I haven't heard that discussed.
Our public health core CBOs are funded, but we will never turn down more funding to do more great work with them.
I know, but are you asking for it? In other words, what you're saying is so the CBOs that are part of the public health fund, is that what you're saying? They are all funded?
The public health,
You have your own core.
public health
You have your core, right.
community-based organizations are funded on contracts with the health department.
Okay, so you think you have enough? Because it sounds to me like there are a lot of folks who are not accessing healthcare. And there's a reason for that, which is that they don't know about it, they don't feel comfortable with it, et cetera.
There's always more we can do with more funding.
All right.
And if I make an additional point, I think in terms of folks that haven't accessed healthcare, the NYCC Care CBO is a really important piece of that as well. Between those and between the CBOs for the public health core now, I really do believe that our grassroots approach to COVID has been why we've been so successful as a city. And I really do believe we need to make sure together, from your perspective more than mine, that we're continuing to meet that.
Okay. How do you work with the pharmacies? Just out of
Councilmember,
curiosity.
the time expired.
All right, okay.
So we're going to
All right.
come back to you
Okay.
if you want to come for a second round. Thank you.
I just want to ask about the pharmacies, then I'll stop. How do you work with the pharmacies?
Okay. Please, you can answer that.
You mean with respect to continuing to connect people to treatment, vaccines?
Pharmacies are the doctor.
Do you want to start?
Sure. So we have several different programs that the health department does with pharmacies around different topics. So this might be a good thing to follow up with later.
All right, thank you.
Thank you. Turn it over to Chair Narcisse. Thank you.
Thank you, everyone. Like I said, I wish the room will be packed, but we know we're not in the height of a pandemic. But the folks that really keep it going, and everyone in the room, those that submitted their testimony online, I want to say thank you. We acknowledge you for taking the time, because this pandemic is a long pandemic. So we're going to have to continue doing the work. And Dr. Ted Long, thank you. Dr. Celia Quinn, thank you for being here. And before I close, I would like to pass it on for my colleagues to make his closing remark. And because we're done, we're more likely, pretty much. Members of the public, do you have a question?
Yeah.
Oh, so I cannot close if they have testimony. I thought we had done.
You could just thank me.
Okay, so I'll pass it on to Habija, please, so you can take it on. Thank you.
Thank you, Chair, and thank you to the administration for your testimony. We're going to move on to public testimony at this time. We have registrations from Anthony Feliciano, Annabelle Ng, and Alejandro Stain. At this moment, I'm seeing Annabelle Ng present on the Zoom, so we will turn it over to you for testimony. You may begin as soon as you're ready.
Starting time.
Hi, my name is Annabelle Ng, and I'm the Health Policy Associate at the New York Immigration Coalition. We really thank the chairs and council members of the Committee on Hospitals and Subcommittee on COVID Recovery and Resiliency for the opportunity to testify today. The NYCC is an advocacy and policy umbrella organization for more than 200 multi-ethnic, multiracial, and multi-sector groups across the state, working with immigrants and refugees. As researchers continue to uncover the effects of COVID-19 on one's health and why certain individuals develop post-COVID conditions, it is clear that COVID-19 can cause a wide range of ongoing health problems that may last long after an individual has been infected with the virus. And as you have mentioned, the debilitating symptoms of long COVID are not only physical, but also mental. Long COVID has affected our communities and myself personally. For almost a year following a relatively mild case of COVID, I experienced fatigue and parosmia, a condition that made almost all foods smell and taste unpleasant. It became difficult for me to eat and get through my day. And because my doctor had no information about how my symptoms could be treated, I was told to simply wait it out. And just as low-income individuals, immigrants, and people of color have suffered disproportionately from the pandemic and inequitable COVID testing and vaccination, these communities will continue to experience significant barriers to accessing culturally appropriate long-term care, especially for conditions that are not fully understood. Immigrant New Yorkers in particular have suffered reduced access to health services throughout the pandemic because of the state's persistent health insurance discrimination against those without status. Many immigrants still lack access to the long-term care that is required to manage post-COVID conditions. We are really encouraged by the continued partnership with community-based organizations to conduct NYC Care-specific outreach and the elimination of the 6-month residency eligibility requirement, which enables more New Yorkers living in the 5 boroughs to access NYC Care. We urge NYC Health and Hospitals and City Council in its oversight role to ensure that all low-income immigrant COVID long haulers can receive the care they need. And most of all, we cannot achieve true equitable recovery from the COVID-19 pandemic without addressing both physical and mental health needs of vulnerable communities and providing coverage for all New Yorkers, regardless of their immigration status. Thank you for the opportunity to submit this testimony.
And thank you so much for being here. And like I said, it's not popular, but when I have an organization that come on to testify, I appreciate that. And what community that you serve mostly?
We serve immigrant communities from all over New York State, many of whom are undocumented.
Yes. And do you find that during the height of the pandemic, because they don't have document, were they able to get services during that time with the height of the pandemic? Were they able to get services? Or you had difficulty for them getting services? Or were they able to come out, not be afraid to get the services too?
Yes, I think that one of the biggest barriers for them to access services was their lack of insurance coverage beyond emergency Medicaid. That was a barrier that continues to remain for many immigrant communities, despite the progress that we made with the state budget this year for seniors and postpartum people. But we have also seen how, as you have all mentioned previously, people for a variety of reasons did not access care, whether it was because they had to keep working and could not risk losing income, or just having vaccine hesitancy because of history of racism and discrimination that they experienced in the healthcare system. Those factors were things that we all experienced throughout the pandemic.
Thank you. And one of the things the council member next to me, Councilman Brewer, spoke about, so I'm going to pass it on to her. So I'm sure she has questions. Councilman Brewer, do you have any questions for Annabelle from NYCE?
Thank you. Thank you very much. My question is specifically, I know you mentioned New York Cares and insurance as the barriers, but what would you suggest would be the way that individuals who do not get health care now, maybe had a good experience when they were vaccinated, should continue to get their health care? What would be your dream health care for these individuals? I know your organization very well.
My dream. I think it would be ideal and really needed if, like, no matter what language you speak or what culture you come from, that when you are experiencing pain or any sort of health issue, that you can be quickly connected to someone who can help solve and manage that health problem. And for, whatever healthcare setting that you enter to manage those symptoms, that it is a trusted place. And that there is no cost barrier when you have to get medication or get treatment for those conditions.
Right, thank you.
Any question, Moya? No, CM Moya, I have no question. So I just want to say thank you so much for your patience being here with us and be able to contribute to what we're trying to do. Make sure that we have quality healthcare for all and focus on preventive care. And my colleague just mentioned about the housing. It's just like you get one-shot deal, and we know the problem, and having you to testify mean a great deal to all of us. So thank you.
Thank you.
Now, if any more questions from anyone from the public, so I'm gonna turn it to Council Member Moya, Chair of COVID Recovery, so for a closing remark.
Thank you, Chair Narcisse. I just want to say thank you to the administration and thank you to Chair and my colleagues for this great hearing today, and to the public. But I want to just give a big shout out today to M. Balkin, who is having her last hearing here. I can only say thank you so much for the great work that you've done here at the council and for this committee. I'm very, very fortunate to have had the opportunity to work alongside of you. I think you've made us a better place, and you've done really great in ensuring that we were taking on the issues that mattered most for a lot of needy New Yorkers. You've played a major role in how our policies have been developed here, and we just want to say thank you so much for the great work that you've done, and we wish you all the best in your future endeavors. Thank you.
Thank you, CM Moya. And should I go on for M. Balkin, because she had so much patience with us as a rookie coming in for the policy. I know you've been with her for a long time, but for my short period of time, I really appreciate you. For me, like I said, you're the best. Don't get jealous. You're the best. You are the best. You've been very patient with us, and your knowledge, it's unremarkable. You very much, and you're willing to share your knowledge and have patience to teach others. And I appreciate that. Wherever you go, I know you're going to be great, but I'm hoping during my time here, you're coming back. So you can finish your degree and come back. So I want to say thank you to Habani Hahuja. We can say all that for you, but you're not leaving us, and we don't want you to go. As well, I want to say thank you to CM Brewer, Rita Joseph, and Brennan, and Council Member Barron that called in that could not make it. So thank you, and all the one that testified, everyone that testified, and the doctors, everyone. So thank you. Now I cannot stop saying thank you to my staff: Saya Joseph, Frank Shea, Stephanie Lane, Kim Robinson, Bonnie, Irina, and Evans. Thank you, because while I'm here, you keep the office going. So I thank you so much, and God bless. I appreciate everyone. Thank you. We're done.